Good evening, doctors. Welcome to the second TOC webinar brought to you by Science Integra with an educational grant from Juventus. The topic for today is CVD effects on corona and corona effects on CVD. We have today a star lineup of doctors, and setting the tone for today is none other than Dr. Professor Soumitra Ray. Doctor Professor Soumitra Ray is a professor at Vivekanand Institute of Medical Sciences in Kolkata. He is a fellow of European Society of Cardiology and American College of Cardiology. He was the past Vice President of Cardiological Society of India. He was instrumental in publishing the CSI guidelines on STEMI and heart failure. So, without wasting much time, I now request Dr. Ray to take the center stage.
Thank you, Minal. Good evening to all and welcome all the audience to this evening symposia, as you call it. My first pleasant job is to introduce my three esteemed faculty. The next slide, please, Minal. Yeah. First is Professor S.N. Rautre. As the slide is in the background, you can always read. What I will say about Dr. Rautre is that nowadays in India, no cardiology conference is complete without the presence of Dr. Rautre as a faculty. He is the brand ambassador of Orissa, not only in India, but abroad in the field of faculty. He is a prolific speaker and a great organizer. He was instrumental in starting the CSI heart failure registry. He was the helmsman of that. So, and he is a musician as well. So, welcome our Bhumiputro, Dr. S.N. Rautre, Professor of Cardiology and Head of the Department.
Thank you. Thank you for your introduction.
Next, please. Dr. Ambuj Rai, Professor Ambuj. Now, if you go to Google search, see the Cardiology Department of AIIMS, Delhi, you will see it's a Navaratna Sabha Vikramaditya. It's star-studded jewels. I'll just give one anecdote. Allow me 1 minute time. You know, there are 9 jewels in Vikramaditya's court. But Vikramaditya was fond of Kalidas. Others were jealous about why Kalidas is the preferred one, chosen one. Even the other court people thought Vikramaditya was unduly favoring Kalidas. Vikramaditya didn't say anything. One day they were all roaming around in a field in the afternoon stroll, and Vikramaditya saw a tree struck by lightning of a thunderbolt and burnt. He asked Bhababhuti, would you care for describing the scene in front of you? Bhababhuti said, yes, Maharaj. Shushkam kashtam tishtati agre. And everybody said, wow. What mastery on language, what alankar, what anuprash. Vikramaditya smiled. Kalidas, will you have a take? Yes, Maharaj, as you say. Nirashatarubara purat bhag. Everybody was silent. So beyond knowledge, beyond anuprash, beyond alankar, there is something else. That is called sophistication. It pacifies your heart, it balms your wound. So welcome Kalidas Ambuj Rai to this panel.
Thank you. I surely don't deserve that, but thank you so much.
Next slide, please. Of course you deserve, otherwise I won't have told. I don't tell lies. Now the Rishi Shetty, oh my. Now come to Lucknow. Choose one person from Lucknow who represents the Lucknow culture, Lucknow Gharana, Lucknow Nawab Khandan. You choose this person. And rarely you will see a person whose name tallies with the personality, the Rishi. And you know, he is, of course, you can see what he is. He is a great musician, vocalist as well as instruments. He has got a whole music room in his house. And he has written a novel recently called The Sage. The Sage, Rishi. I don't know whether it is an autobiography. Only Rishi can tell whether it is an autobiography. But he is a multi-dimensional, multifaceted, sophisticated Lucknow person. So welcome Nawab Rishi Shetty to this forum. I have got two more people to introduce. One villain and one a silent hero. Who is the villain? From the day one, I am perplexed by the name of the villain. Such a lousy, nasty, abominable bug has got such a sweet name, Corona.
Corona.
So close to coronary. And if you see COVID, CVD is implied in COVID. So is this closeness to heart just in the name, or there is some more dark liaison? We'll find out this evening. And lastly, the hero in the background, that is the Juventus persons. You know, I tell you here, starting from the choice of the caption to the questions to the panelist, they gave me free hand. No interference, nothing. And of course, you will know this subject. After the questions, you will see there is no commercial involvement at all. No product we will discuss today. So hats off and thanks to the people in the background behind the curtains. Now with this, we have got 12 questions today. Very specific, focused, laden questions. Each panelist will have 4 questions to answer primarily, and the others may add on to the answer. At the end of the day, if you still have some clarification, the panel will be happy to discuss with you all the subjects related to this. With this, I go to the first question to Dr. Ombuj Rai. Do comorbid cardiometabolic conditions increase the chance of COVID infection?
Thank you, Dr. Ray. Like a true professional, you've started with a yorker and a difficult question. We know a lot of things are evolving, and when we are answering these questions, I would like to say on behalf of the panel also that a lot of things are evolving. We don't know too much, and we have to be answering with great humility because things might change. But as of now, presence of comorbidities or cardiometabolic risk factors do not, thankfully, seem to increase your chance of getting COVID-19. What increases your chance of getting COVID-19 are not following, if I may call, COVID preventive etiquettes. And those are not following social distancing, not following hand hygiene. So those are the things which everybody should follow. We should respect and support our governments and the whole healthcare machinery, which has been working to fight this pandemic by following their instructions and wherever possible, avoid non-essential contacts. So that's my short answer to this, that thankfully it doesn't increase your chance for having the infection. But as you'll get in the next question, you have to be extra careful because probably you have more severe complications.
Thank you, Dr. Rai. So the message is, if you are hypertensive, diabetic, or have heart disease, you don't have to be extra panicky to get the COVID infection. And from Wuhan, if you see the percentage of patients, COVID positive patients who had hypertension 30%, diabetes 20%, cardiovascular disease 10%. Exactly the same prevalence in the common society. 30% hypertensive, 20% diabetic, 10% cardiac disease. So as it is a great equalizer, COVID does not prefer hypertensive or non-hypertensive. So exactly the same percentage is maintained when you see the incidence of COVID infection. So one good thing that a premorbid condition does not necessarily expose you to the infection. As you said, we have to have normal or equal measures to be taken by everybody. Excellent, thank you. Next question goes to Dr. Raut Rai. If infected already, do comorbid cardiovascular conditions worsen the outcome?
Thank you, Dr. Rai. One positive message you gave, that those who are having comorbid conditions, they are not at increased risk of having COVID infection. So that's why this is a good message for the public and also our doctors. Now come next thing. As per the hypothesis goes, this diabetes, elderly and smokers, they have immune compromised state. And in immune compromised state, they're likely to have more severe disease, thereby resulting in event rate which is higher. So actually, this is what Ambuz told and you told. The evidences are few because this is evolving virus. We do not know. We are blind persons looking at an elephant, how it looks. But whatever trials has come, most of the trials has come from China. Let us see the 3 trials I will quote. The most important trial that quotes the prevalence of case fatality rate. Case fatality rate, they see the totality 2.3%. And if you see the elderly, if it is 70 to 79, it is 8%. If it is very elderly, more than 80, then it is 14.8%. Next come the disease concern. Disease concern, if it is cardiovascular disease, then it is 10.5%. Next come diabetes, it is 7.3%. Then comes pulmonary disease, 6.3. 7.3 is diabetes, 6.3 is pulmonary disease, 6% for hypertensive and cancer, 5.6%. That gives a message. Once infected, they are having bad prognosis. Other trial, they have seen, they have find out who are having cardiac infection. I mean, they have taken TOC and from other values, those who are having myocardial involvement. If the myocardial involvement is there, some are involved, some are not involved, they compared the patients with myocardial involvement mostly had hypertension, diabetes, coronary. That means if infected, then these group of patients are more prone to develop severe infection. In the third trial, that divided this group to 4 groups. One is they take into account the cardiovascular disease and troponin T level. And if the cardiovascular disease and troponin both are negative, the prognosis is very good. If both are positive, the prognosis is worst. Then comes the 2 things in between. Then cardiovascular disease is present, but troponin is negative. Another, no cardiovascular disease, but troponin positive. They found the patients with troponin positive, no cardiovascular disease, they had a worse prognosis than the other group. That means there must be some direct effect of the coronavirus on the heart and cardiovascular system. Thereby, even those who do not have cardiovascular disease, they have a worse prognosis. So I can say in one word, once infected, those who have comorbidities, they are having a chance of more severe infection, thereby resulting in death or other events.
Excellent, Dr. Ratha. As you said, that diabetes and other things. So, even for a cataract operation or dental extraction, a diabetic person has got worse prognosis. What is not very clear, only today it is also published in European Heart Journal, that why hypertension makes such a bad prognosis. Actually, it is not very clear whether it is just a history of hypertension or uncontrolled hypertension or hypertension with target organ damage. Then it makes sense, hypertension with heart failure, hypertension with CKD, it makes sense. But just a history of hypertension, how it affects the prognosis, people are scratching their head, what is going wrong. Of course, there are a lot of scratching is still in store, and perhaps we'll all get bald by scratching till we understand COVID by the end of the day.
Yeah, I can put a view because hypertension is most prevalent of the all other conditions. That's why maybe it is. Maybe
coincidence. Yes, Dr. Rai, you have something to say, Ambuj.
Yeah, I would just like to add a bit of a sobering on this data. If you see, it's almost been showing 5 to 10 times higher risk if you're hypertensive, diabetic, or CHD. But again, we have to be careful. The studies which are coming are a little light on statistics, and you have to look at all the associations are univariate. In fact, there's only one paper in Lancet which looks at a multivariate adjustment analysis, and that shows that actually CHD was not a risk factor. It's a small study from 190 patients. So So I would say the risks are not as high as they're being projected. So the patients, if they develop COVID, need not be as terrified, because you're not adjusting for age. Hypertensives, people with CHD are older also. They are smokers also. They may have COPD. So standalone, one risk factor may not be as bad as it's being made out to be. So we need to closely look at these studies and not create too much of a panic. Yes, they are going to have slightly worse complications, but not as is being projected in the current era.
Yes.
Yes, exactly. Because that multivariate analysis did not find any of these factors as is one of the important factors.
Exactly. So maybe age is the most important determining factor associated with others. Now coming to the sage, Rishiji, does COVID infection cause any cardiovascular disease per se?
Well, thank you, sir. First, I did not get an opportunity to thank you for the kind introduction. So thank you for that. And before I say anything, you'd have to excuse I have a little sore throat, although I hopefully, so we are keeping our fingers crossed, like let's say. But I would like to second Dr. Ambuj's statement that in a disease that is changing so fast, we really cannot say early days versus late days, but what we can say are the things and the data and the knowledge is changing by each passing day, and what we are hypothesizing now may not be true in the days to come. And coming to this question per se, whether COVID infection can cause any cardiovascular disease per se, I would say it's a pertinent question, but a tricky question, and the answer can be, both yes or no, depending upon how you look at it. So coming from what we know and what we do not know, we certainly know that many patients, especially in the second or the third week of the infection, and the serious kind of infections may present to our emergency and ICUs with the clinical diagnosis mimicking cardiomyopathy and sometimes as acute coronary syndromes. This we know. But the initial data that came out of Italy also showed that many a time these clinical diagnosis of myocarditis was actually not proven by biopsy. And when you looked at biopsy, there were some inflammatory changes, but the presence of viral RNA in the myocytes has theoretically not being demonstrated till now. So the hypothesis that is floating around is, and most accepted these days, is that it's the hyper immune response, the cytokine storm, which causes the cardiac inflammation. So if you ask me whether the virus infects the heart, the answer probably at this time is no. But the immune response of the body in response to COVID infection sets in a chain of events which produce a cytokine storm, and that gives rise to an inflammatory sort of myocarditis or myopericarditis, which may present with both heart failure and sometimes mimicking acute coronary syndrome. It can present with depression of LV functions, leak of cardiac enzymes, ECG changes, and so on and so forth. So, I mean, in those cases where clinical diagnosis of a myocarditis is made, probably the use of steroids to control that cytokine and hyperimmune response has some role. In acute coronary syndrome that have been presented in COVID patients, there have been some initial data to suggest that patients who are having ST segment elevations and myocardial depressions, when they were taken up for angiogram, these were diagnosed cases of COVID infection. When they were taken up for angiogram, the disease was actually not an obstructed sort of a disease in the coronary artery, again suggesting that it may be a demand-supply mismatch or a plaque rupture that is induced by the inflammatory responses, which may be responsible for these MIs. So while we know that the virus is not affecting the cardiac tissue per se, but indirectly, because of the hyperimmune response, the cardiac function is being affected. So the answer is yes or no, depending upon how you look at it.
Yes, Dr. Shetty, you're absolutely correct. And there are anecdotal reports coming of Takasubo syndrome, yes, reverse Takasubo, and 1 or 2 episodes of complete heart block. These we see even in dengue. I have seen many dengue patients with transient complete heart block. And stress can cause Takasubo, and it's definitely a stressful situation. So these things happen. Acute coronary syndrome will come later on. Actually, we are all seeing a fall. Will come later on. But today I was reading Dr. Ferrari's article, only published today. He said it's counterintuitive. It's such an storm in the body of high CRP and high inflammatory marker, the plaques become vulnerable and there should be more plaque rupture. So why are we seeing less ACS? Anyway, but we'll see, we'll discuss it later on. So excellent. The first round is over. 3 questions done. Second round, to again Dr. Ambuj. Any special issue in hypertension management in this era?
Yeah, thank you, Professor Ray. I know you're angling here rightfully at the ACE inhibitor controversy, but since you said hypertension management, I would, say that let's look at the larger picture. And these are difficult times, difficult to access medicine doctors. So my advice to all the hypertensives and physician managing hypertensive is to keep their patients motivated that they must continue on their medicines. Whatever the difficulty in procuring them, they must take that because there is a high chance now your physical activity is low, there is anxiety. So if you're not able to access your physician, continue with that medicine, whatever you are taking. And if you can have access to home monitoring, hypertension management makes for a perfect case for telemedicine, and that's been allowed by the new guidelines put out by the ministry. Follow that. And as far as possible, if you can contact your physician with a monitoring chart, if possible at home, look at that and do that. If not, continue with your medicines. Do not stop that. Coming to the, what has been more in the social media and everywhere is the ACE inhibitor controversy, whether you should continue or not. And this comes from the fact that the portal of entry or the dwar of the novel coronavirus is ACE2 receptors present in the lung. That's where it enters through the alveoli and causes the havoc. And these ACE2 receptors are also present in other organs, especially heart. So what people on ACE inhibitors, it's been seen from SARS that their ACE2 receptor levels are upregulated, and therefore this fear that you may have higher susceptibility if you're on ACE inhibitor to a novel coronavirus infection. However, there is data to the contrary, and it shows that there's animal studies done with losartan where you showed that when you used losartan in these animals, actually the outcomes were better in terms of the LRTI because they reduce the local angiotensin 2 receptor, and that kind of helps mount the correct response to the infection. So the data is both ways, and as of today, there are multitude of societies, national and international, including the guidelines which we had circulated from ICMR, which clearly shows that if you are on an ACE inhibitor, please do continue that, whether it be for hypertension or heart failure. And there is no need to switch your antihypertensive right now. Continue with your RAS inhibition.
Thank you, Dr. Rai. I'll just 1 or 2 googlies I'll give to you. I'll come to that later on as well. As with hydroxychloroquine and other drugs people might take, chance of QT prolongation, does beta blocker has got an edge in this era as antihypertensive? Will it protect against QT prolongation or sudden cardiac death?
I would not speculate to say to go over to beta blockers at this stage. It could be counterintuitive many times when you require the adrenergic drive to fight the illness. So it may be, again, counterproductive. So in the absence of concrete data, I would not, play around with the medicines on which you are kind of chronically well controlled.
So don't go for the shot. Keep the bat up. Second Google is coming. Is that, say, newly diagnosed hypertensive you are seeing now, will you by choice start with an ACE inhibitor ARB or will wait for the time being?
Yeah, you're starting with Yorkers and now Googlies. You're giving it a time. But I would possibly avoid RAS inhibition if you're not on a RAS inhibitor right now. That's my question. That's my personal advice. I don't have any evidence to it.
I will second it. Yeah.
You've got support behind that. It's again coming in the SEC guideline. Unless it is really indicated and needed, you do not start per se during this period. My third observation is that, my personal observation, you say, as I said, the incidence of hypertension, diabetes and CVD are 30, 20, 10 in China experience. And all these 3 conditions, most of the patients are on RAS blockade. for hypertension, diabetes, and CVD. So if RAS blockade drugs would have increased the chance of infection, this 30-20-10 would have been 50-40-30 in terms of infection. But we haven't seen. It's the same as in the general society. So that indirectly again proves that perhaps ACE inhibitor ARP are not bad for you. And as you said, very clear message, please continue with the present set of medicine. Of course, if the patient has got cardiogenic shock and stuff, that is a different issue, but otherwise just carry on with your antihypertensive. Any quick comment, Dr. Rautre?
Yeah, no, I also second this thing, because if we are not giving the patient ACE inhibitor, then need not start if we have other alternatives.
So you are thirding it, not seconding it.
Yeah, yes, thirding.
Yes, Rishi, fourthing it.
Am I also allowed a googly? I mean, is there? We are clubbing ACE inhibitors and ARB in one bracket here. Is there a difference between the two? Because it's actually the upregulation of ACE inhibitors, ACE receptors, which will happen with ACE inhibitors and not happen with ARB. So,
right. Yes, this googly is nobody has answered. Everybody has took their bat off, and of course, ACE inhibitor may be potentially, theoretically, more damaging than ARB. And you know, there is some good thing is that there could be soluble ACE inhibitor increases with these molecules, and the soluble ACE2 can take up the virus so that the virus does not go to lung and heart. Maybe it is protective. So we are really in very dark ground. Oh, great. Next, any special issue of diabetes management in COVID era, Dr. Rautre?
Yes, coming to diabetic, you see in the population, almost nearly 10% are diabetic. So they are very much aggrieved. They are very much conscious that they may have more of problem. But one thing is clear from the very beginning, they do not have more chance of getting infection. But once infected, they are likely to have more severe problem, as has been shown by earlier studies on respiratory infection. All respiratory infection, pneumonia in earlier studies, the viral infection, they usually cause this more of diabetic complications. And cardiogenic shock secondary to septic, septic shock is also more common. As per one study from Wuhan itself that shows they have taken the endpoints as ICU admission, going for mechanical ventilation, and death. It has been seen diabetic are more prone to all these three if they develop infection. But most important thing is that if you have a good glycemic control, whatever drug you are taking, you are more protected against risk and spread and severity of infection. So they should have a better diabetic control. The glycemic control is very important. And second thing, the immune building nutrition. That means particularly protein, unless they have a renal failure, and citrus food they should take, and they should have usual exercise, not outside, even at home. And they should carry if there is associated with diabetes is associated with hypertension or some other problem, they should be more careful. And this social distancing and personal hygiene is very important for them. And if they get symptoms suggestive of coronavirus infection, they should immediately inform their doctor or the healthcare professional. And I want to say two things more. This is same as type 1 and type 2 diabetes. If that type 1 diabetes, likelihood that DKA, diabetic ketoacidosis, is more likely. And drugs. All diabetic drugs can be given safely. There are questions have arisen regarding the use of glitazones. Again, that is not proved. If somebody taking glitazone, let him continue. If not taking, do not start glitazones in diabetic patients. And next thing is insulin. So if it is on well controlled on oral hypoglycemic agent, he should continue that. But he developed an infection, admitted, still continue the same thing. But he needs ICU admission, then the question of better control with insulin arises. So the take home for them, they should not panic. They should have a good glycemic control. They should practice more of social distancing even at home and self-hygiene.
Excellent. So the bottom line is that the good glycemic control is extremely important at this phase of the in the world what is happening. And do not reduce or stop the dose of your own. Rather, check more frequently. If it is a home monitoring, go for it. And if it is lab monitoring, try to get the lab values as frequently as possible to keep your sugar control absolutely within range. So that in an unfortunate event, even if you develop corona, if you are the virus, if your sugar is under control, your prognosis is as good as any other normal person. So that remains extremely important message that diabetes control becomes even more critical at this phase. So do not play with your diabetes. Excellent. Next question goes to Dr. Rishi. Any special issue in ACS management during this period? It's a huge subject.
Sorry.
I can hear you. Yeah.
So, let me club the management and a little bit bifurcate it between non-ST segment elevation MI and the ST segment elevation MI. When a patient with acute coronary syndrome presents to our emergency, it's really a catch-22 situation that the hospital would face, and we are facing every day. At one point of view is that if we continue with the standard practice that we have been doing till now, we risk exposing our staff and the hospitals to a great degree, because most of these patients who present to cardiac emergencies, it will be very difficult to screen them for COVID, taking history so fast and doing the diagnostic tests. So I think being a little conservative is the way to go forward. And if you think about the non-ST segment elevation myocardial infarction, it's judicious to little bit deviate from our strategy in stable patients of non-ST segment elevation MI, our age-old practice of the early invasive therapy. And it's we can put these patients on the good optimal medical therapy and take the patients up a little later on in their course of hospital stay, especially if they turn unstable, to the cath lab, and during which time we would have the opportunity to screen them properly and probably do a diagnostic test wherever we are suspecting a COVID infection. The ST segment elevation is a little bit more problematic situation because we have to take a decision whether to take the patient up for primary PCI or not, because the difference between primary PCI and thrombolytic therapy, we all have been accepting this fact that primary PCI is the way to go forward. I think the triaging should start in the ambulance and before the patients enter the hospital premises. And if the patient is a diagnosed or reasonable degree of suspicion for COVID infection, then probably he should be treated a little differently. We can consider thrombolysis or a primary PCI in a dedicated COVID lab where other cases are not being done, with absolute precaution for the healthcare workers in terms of the PPEs being mandatory for every person who's present within the lab premises. In those patients who are clearly negative for COVID and they are very low risk for COVID infection, and who also present with high risk MIs, for example, young patients with anterior wall myocardial infarction, we can go in for the primary PCI straight away. But if we go down a little slow for low risk STEMI patients and for suspected patients, if we follow the initial strategy of thrombolysis and maybe taking them up later when we have conclusively proved or disproved COVID, seems to be the most reasonable thing to do. In this breath, I would like to just add that those labs that are considering, those hospitals that are considering giving suspected COVID or diagnosed COVID patients invasive care should have at least 2 labs. So that implies very clearly that a single lab hospital should not attempt to primary PCI or a non-diagnosed case who has heart failure, who has some degree of suspicion for COVID infection. They should not take these patients up, because at one point we might be trying to help the patient, but if we end up compromising and quarantining the hospital, we may end up harming a larger number of patients in the times to come. So if we are considering an invasive strategy, the hospital should have at least 2 labs, and one of which should be dedicated to the management of diagnosed or suspected cases of COVID infection.
Excellent, Rishi. And you know, you are the convener of the STEMI guideline by Cardiological Society of India, published 3 years ago. So that guideline still holds true for that group of patient. Number one, for STEMI, who comes after 12 hours, or if he comes within 12 hours, but with a very low suspicion of COVID and asymptomatic from COVID. In other patients, if he comes within 12 hours or any suspicion of COVID or symptoms suggestive of COVID, then we go for thrombolysis. And we know that we have recently published from CSI again a statement as orchestrated by Dr. Mrinal Das and Dr. Praful Kerkar. We are suggesting that go for the best thrombolytic available. Don't compromise with streptokinase with 60% success. Go for retiplase or tenecteplase with 90% success. Number 2, pharmacoinvasive, forget about it. Rescue, yes. If there is further destabilization and you think there is no revascularization occurred, then go for rescue, but not a routine pharmacoinvasive.
Right.
And primary PCI, as Dr. Ferrari only told today in the ESC, that the chance of dying with STEMI is more than chance of having COVID. But that is for the patient, not for the doctor. The doctor is neither having STEMI nor having COVID. So here the balance is tilted. I will come to that issue later on. So here we have to protect ourselves first, protect the cath lab technician first, protect the hospital first. As you said, if the hospital goes to quarantine, everybody, then another eligible person won't get the treatment. So we have to make a very fine judgment and balance over here. And as you say, less and less of intervention, more and more of thrombolysis, and quick discharge if the patient is stable. Do not keep the patient unnecessarily in the hospital. Chance of infection gets higher. Excellent, excellent, Rishi. Thank you. Now we are halfway through, 6 questions done. Round 3 starts with Dr. Ambuj Rai. Any special issue in heart failure management in this situation?
Yeah, very good question. Heart failure patients are those patients I think who are most susceptible to COVID-19 once they develop it, to adverse outcome, I would say, once they develop it, because they have a low cardiopulmonary reserve, as we all know, because of the poor cardiac function, poor respiratory function. So that is one of the important things. But the 2 essential things in management that come to my mind is many a time COVID-19 symptoms can masquerade as heart failure symptoms. It may not be easy to distinguish whether the person is in ADHF or he's having COVID-19, especially because we've seen a lot of these patients, because of their probably poor immunity, do not mount fever. If you look at the paper which had come initially, a series of 4 patients from China, said that all 4 of them, heart failure patients, when presented with COVID-19, may not have a fever, which is right now one of these conditions for testing. SARI, you diagnose SARI if you have fever with one of those breathlessness. So for me, for the health system, we must have a very low threshold for testing for COVID-19 in these patients, which is for the good of the patient and good of the healthcare workers and the health system and the hospital in general. So I would say in these patients, they are susceptible to worse outcomes. They can masquerade as COVID-19, and the patient and the physician may not pick up the diagnosis of COVID-19 because the symptoms may be similar, and they may not have fever. But the last point is that if they are again on RAS inhibitors and they are stable, then we continue them on RAS inhibitors as of now. So these are some of the important points that we need to have in mind in heart failure management.
Excellent, Dr. Rai. But before going further, I see my name is here, Striya. Actually, I haven't changed that. That COVID didn't change me from Soumitra Rai to Striya. It is my daughter's computer I'm using, and it is my daughter's name as it is. So apology for that. Now you have just struck the nail on the head, Dr. Rai, that management is grossly same, but there is a possibility of pulmonary edema or ARDS And the judicious use of diuretic is very important in this case. We tend to, as cardiologists treating a heart failure, we tend to overuse diuretic. Perhaps here is the case we have to be much more cautious about using diuretic when the patient's main symptom is due to ARDS and not due to heart failure. They may camouflage. And you know the BNP and TOC can go up in either condition. So absolutely right. We have to be very judicious in treating our heart failure patients. What about using anticoagulation in heart failure? Per se, we sometimes use anticoagulation in heart failure with AF, and here there is a possibility of microvascular embolism and thrombosis. Will you give anything? Something?
Yeah, so, anyway, there's data that, and there is a trial actually of TPA in COVID-19 seriously ill patients because of the high D-dimer and FDP, which has been seen, and there's a prothrombotic state. And that would hold for most of the patients in ICU. They must be on heparin prophylaxis in terms of at least getting one dose of low molecular weight heparin. But if their D-dimers are high, a lot of people are now saying that they might be better treated with a full dose of anticoagulation. But because there is a procoagulant state. So that holds true for general COVID management and heart failure patients. So again, we might have to have a lower threshold for anticoagulation in moderately and severely sick COVID patients.
Thank you. I think you won't go for a CRTD or ICD at this point of time. If the patient is stable and it's not a serious need of that, you can always defer these invasive procedures for the time being, isn't it? Yeah,
definitely. There's a lot of talk. I think that question is not there, but if I may take your permission to add, there's a lot of talk about cath lab. There is also a much more commonly done investigation, echo, and that's done in heart failure patients. And there is a whole set of guidelines by ASE, and it's very nicely said that even for echo, defer it if it's not needed. So a stable heart failure patient, I would not bring him for an echo. Similarly, for other patients, defer even echo, they're saying, if it's not mandatory. If you have to do it, if it's a COVID positive patient, then you have to take all the precautions for the lab and the personnel, and especially TE. TE can be aerosol generating procedure. So minimize TE. If you do TE, use full level 3 PPE protection for doing echocardiography. I mean, that was not there, so I thought I'd bring up that because that's commonly done by our physician friends and cardiologists.
And sterilize everything, the echo probe, your stethoscope and everything. What I still cannot get the answer is how to sterilize the blood pressure cuff.
I think 70% alcohol sterilium will be probably the best way to do it. I mean, that's on
the cuff you spray after every checkup. I could not fathom the answer. This is only where I have stuck. I can clean my stetho, I can clean my pen, I can clean my specs. How can I clean the blood pressure cuff? I do not know.
That's a good practice. Rishi, you have some ideas on that?
I don't know. Prayers, pray.
Now, next question to Dr. Rautrai. Any other cardiovascular drug-related issues, as for example, using antiplatelet, statin, amiodarone, beta blockers, etc.? Dr. Rautrai.
Thank you, Dr. Rai.
In using statin or amiodarone?
Yeah, I'm telling. If you see all the drugs that is required for our patients of coronary artery disease, starting from aspirin, beta blocker, ACE inhibitor, all to be continued. Because there are high thrombotic phase. So our aspirin and clopidogrel or other antiplatelet drugs is a must to continue. The question comes only with statins. You see, statins gives extra protection, particularly if there is infection or inflammation which is giving rise to myocarditis is one of the hypotheses, though it is not proved. Even in that case, statin will definitely have beneficial role. So statin is a must, whatever dose is required. If patient have myalgia or suspicious of skeletal muscle injury, in those patients, we should be careful, we should be judiciously used it. If there is rhabdomyolysis, say for example, in those cases, we'll have to discontinue statin, and after some time, we can start statin. But statin is the most useful drug of all these. And if the patient is having heart failure or for some reason is continuing ACE inhibitor, that has to be continued, that cannot be discontinued. That has got immense, if it is discontinued, likelihood of complications is very high following the withdrawal of the ACE inhibitor.
What
And
about amiodarone?
Yeah, coming to the amiodarone, because amiodarone is a drug which has been seen to reduce the viral replication and viral expression, thereby reducing the viral load. So there are studies where amiodarone has been tried to prevent coronavirus infection, not this coronavirus. Earlier, they have even tried in Ebola and all, but due to some reason, that studies was stopped underway. But the other part of it, the amiodarone is a drug which can increase the QT prolongation. But if you are giving SCQ or azithromycin or some other drug in combination, if you give amiodarone, you will have to be very careful. Another point for statin has been shown to prevent morbidity and reduce the death in patients with ventilator-related pneumonia. In those patients, statins have been found to be very beneficial. Regarding the beta blocker, as we know, it's reduced the sudden cardiac death. That it has to be continued. The other part we are discussing, the extra protection, that is not known. Coming to some patients, some trials are there on TPA. TPA has been found to be beneficial, but again, that is again not in coronavirus, then in some setting of pneumonia, they have been shown to be beneficial. But, yes.
And the usual pneumonia vaccine and flu jab, will you continue those in this situation, or will you withhold it for the time being?
I think if they have taken it, it's okay. But my view to withhold at this time, because we do not know what effect it will have.
So they can always wait for a couple of months anyway.
Yeah. But I think we should take the opinion of other panelists, what they are going to tell on this use of influenza vaccine or pneumonia vaccine. But if the patient is elderly, they're high risk. But at this point of time, giving this, I don't know whether it will give extra protection, extra benefit. If they are already given, then it's okay.
Yes, Dr. Ambuj?
Yeah, I would differ a bit. Lot of this, otherwise also a flu season which is coming up. And you can mix, people are already showing H1N1 infections also, which can prevented by the current jab that we have. And there is a chance of secondary sepsis and secondary infection in these patients. So I would say, as far as possible, continue with the recommendations. So continue with the flu shot, which is now quadrivalent flu shot, and where indicated. And that is in patients with heart failure and patients with coronary artery disease elderly. So Rishi, I think that should be continued.
Rishi, any comment?
I think I would second Dr. Ambuj's statement.
Right. So one bottom line is that continue with all the medicines, continue with your scheduled vaccines, may not be start at this point. You can defer always 2 months. Anyway, they act after some time. So they don't act instantly. And thirdly, if many of us are now on hydroxychloroquine for the recommendations. If we are on amiodarone, we should have an ECG done to begin with. If we are not on amiodarone, perhaps it's not needed. We come to that later on. Now, next question comes to Dr. Rishi. Any change observed in the cardiovascular disease incidence over last 2 months? Very interesting. Question from my heart.
No, so it's a very, very interesting question and very, very interesting scenario that we are seeing. It's called the case of missing MIs. Are we really missing those MIs, or are they not, happening actually? So most of the centers across the globe have conclusively declared that they are receiving less number of acute coronary syndrome patients, less number of STEMIs as compared to their usual field of work. And the decrease in number has been anywhere between a 20% in some centers to more than 70% in some other centers. And we can also say that previously, whereas we used to receive more than 20, 25, 30 sometimes acute coronary syndromes in a day in our hospitals, we receive like less than 10 or maybe 5 or 6 at some day. So there can be only two scenarios. One is that those acute coronary syndromes and STEMI are happening and they are not reporting to the hospital. Let's consider that first. It can be because of the lack of transportation. It can be because the lack of the patient continues to tolerate the symptoms home. They don't call up the ambulance services. In Western world, when you call up the ambulance services, they are actually preoccupied with COVID work. And so the other diseases get backseat. And there is always a little bit of a hesitation in patients' mind because they treat hospitals as another source of infection. So a patient would avoid going to the hospital if he can, until and unless he is really compelled to. But if we believe this hypothesis that there are MIs happening, but they are not reporting to the hospital, then they should be dying at home. And it has been shown from the US data clearly that the overall mortality is actually, the more patients are dying of COVID, but the overall mortality is going down. And since cardiovascular diseases are the prominent cause of mortality, if more MIs are happening at home, there should be an increase in mortality. So this is not happening. So what maybe if you sum everything together, maybe the less number of acute coronary syndromes are happening, STEMIs are happening, various anecdotal, yeah.
Just one interference before you go to the second postulate is that if we think they are happening but they are not dying, then what are you doing? By primary PCI, by thrombolysis, we really reducing mortality? Or if they live to stay at home with a cup of tea and with the family surrounding, they really live? This question is open now. Nobody can answer at this point.
Yeah, but
Trials in the past may go down the drain. If we can prove that they are having heart attack, but they are living happily in house.
Yeah, I mean, it would be actually good news for the patient and society per se. And as we know that in these times of lockdown, we have realized how little we need to be happy and to be satisfied. So this may be a revelation, but the anecdotes to say that these things are happening in a lesser quantity, people are saying that people are resting more, they have less anxiety, they are probably taking their...
The second part you are coming, now explain that, sir. That there may be really less incidents. Now tell me about it.
Yeah, so really less incidents, it can only be hypothesized, and the anecdotes are that they are smoking less because they are indoors and because of the family pressures. They are now more tuned to following medical advice because of this fear of diseases lurking. So they are taking their antihypertensive medications. Their BP is lower. The stress levels are lower. They are sleeping more, and they have less triggers for MI if we do not consider any family member to be a trigger of MI. So they are having less triggers of MI. But this is not a reason to celebrate if it's happening, because once the lockdown is over, all these things are going to get back to normal.
So the important thing is that also there is less pollution, more exercise, less of junk food. Yeah. I have collected all these factors. I have written a letter to Jima regarding that. But then we all know that these are the risk factors which we can control. They will give benefit. But how come they affect the incident within a week, within a month? That is tremendous. If it really proves to be genuine, then that will be a new epidemiological floodgate will open. That you can reap this benefit within a month of changing your lifestyle.
That's a very, very interesting thought. And that can only be explained, a difference in such a short difference can only be explained by the fact that these factors are triggers for MI, triggers for plaque rupture, and not the development of atherosclerosis.
No, they affect us. They affect us nicely in long term. But within the short period, if they can change, that will be a discovery. And then people will be more and more motivated to stick to that lifestyle. I think there are a lot of things, good things will come, Rishi, after we get the whole situation. I hope a lot of papers will come also regarding this. Yes, Dr. Rauta, any quick comment?
Yes, yes. One of the things is that they're less accessible to the hospital now because of the lockdown and all the things. They are not able to come. That is one fact we have to take into account. But most important, what you told, the lifestyle. Maybe the lifestyle is very important. The earlier lifestyle, what we are having, definitely proves to be superior. The time will say.
As Dr. Rishi said, that in US they are saying less mortality. You don't have to go to US. You just ring your local crematorium.
Right.
I was talking to the Burning Hut people. Oh, no dead body. There were 10, 12 dead body every day. Now there are 2 dead bodies. So even if you can hide from the hospital, how can you hide from the crematorium? You have to go there. So really there is less death. Cherish that. That the next question, the last round, we are coming to Dr. Ambuj Rai. Any special role of yoga, pranayam, exercise, and diet in this situation you advocate?
Yeah, I think this is a very relevant question. And I think people generally think that will be the first casualty because of the lockdown. You can't do your physical activity, you can't go out, you can't go to the gyms. But I would like to differ here because, and this is from a personal experience, because, I have realized that you just need an 8 by 4 feet space, a mat to do all kinds of physical activity, whether, of course, yoga, pranayam can be done at home. And to aid us, there are multitude of very good apps which can help you do that. And we must make use of that. And even for the more, advanced people who want to do who are fitter, like Soumitra, who wants to do tough cardio exercise, there are excellent apps. And one of them I use is a Nike app. And if you do a half-hour session of that, you'll be sweating like crazy. So there is no reason why the whole level of menu of the level of physical activity is available. The whole entire menu is available. And everybody should use these apps, this technology to continue with their physical activity, because we know that's a level 1 evidence of physical activity for cardiovascular benefit. And there should be no reason to not be physically active, even if you are confined to your room because of lockdown.
And diet, boss? Diet,
I guess, as you said, less of junk food. You're not eating out. You eat at home. You have a lot of time to cook. So most of the people should have.
Now, there is a myth. There is a myth, Ambuj, that this virus cannot sustain alkaline medium. So you rinse your hand with soap, which is alkali. Now, do you want to keep your gastric juice alkaline?
But the portal of entry, I would say, is primarily the lungs. So I'm not sure the GI tract would impact that. So I don't think that holds true.
And we are advocating taking vitamin C and lime juice and fruit juice, which are all acids. So there is a myth that you don't have to keep your stomach alkaline. Acid is good still for the stomach. Okay. So there's Going on that keep your body alkaline.
Yeah, and you had probably told me, off record, to keep alcohol in your system because you're using alcohol to clean your hands. So don't do that.
That is not on the forum. That is after that. This is over.
Yeah.
Number 11 to Dr. Rautrai question. What is your take on, now this is contentious, hydroxychloroquine prophylaxis with or without azithromycin? For us, doctors, for your friends, family, contacts?
Yeah, at this point of time, I feel this is the most important question because see, the letter C has become very important. Coronavirus, China, containment, and chloroquine or hydroxychloroquine. There are many huge and cries in the media, but chloroquine or hydroxychloroquine has been proved to reduce the viral load. It was there even when coronavirus infection was not there. But question arises, the chances of developing QT prolongation and complaint, that is very, very, very rare. You see, so many patients of arthritis and your connectivity disorder, they are taking hydroxychloroquine. Is there any question of QT prolongation? There are many patients taking chloroquine for malaria. but question of QT prolongation is very, very rare. So that part we should take, it is safe. And coming to the use, if you use for treatment, it is 400 milligram twice on the first day, then it is 400 milligram daily for next 4 days. If it is combined with the drugs that can increase the QT prolongation, like macrolide antibiotics, antimicrobial, azithromycin, clarithromycin, erythromycin, or tricyclic antidepressants, or other drugs like quinidine, amiodarone, etc., we should be very careful and monitor the patient regularly. And but the benefit of doubt should be given to the patient age. At this point of time, there is no definite treatment. And coming to the prophylaxis, this is which is very important, because this National Task Force and ICMR has come up, which is the statement that shows it is very specific for two group of persons. One, on household contact of laboratory positive coronavirus patients. So those were household contact. Coming to the healthcare professionals, asymptomatic, but who deals with either suspected or confirmed case of this coronaviral disease, they should take this prophylaxis. And prophylaxis dose is 400 milligram twice daily on the first day, then every week 400 milligram every week for minimum of 7 weeks, or prolonged if they keep in contact with such patients. Here again, one thing they say, if you are taking prophylaxis, you should not think that you will not have infection. So those who are home contacts, they should remain in home quarantine, and all patients, all these persons taking chemoprophylaxis should be aware of the symptoms of coronaviral disease. If they develop any symptom, they should inform and take all that. My take, we should take SCQS, particularly you should not give to children under 15 years of age, and pregnancy, and those are lactating mothers.
So that's very good. Below 15, no. Others, we are more liberal to give it. As you said, if there is a family history of sudden cardiac death, if the person has got structural heart disease, or he's taking some medicine which can prolong QTC like amiodarone we discussed, then we better have an ECG as the baseline. Otherwise, you can give freely, as no rheumatology association all over the world has never recommended doing an ECG routinely before giving hydroxychloroquine. Not to date. So it is a very safe drug. Some visual blurring, nausea, vomiting, rash, etc. can occur. But if you take once every week, they are all reversible. They will go by the next dose. Only thing is that QTC, and you have adequately explained. Excellent. I am for it. I have taken it. All my family has taken it.
Yeah, I have also taken it.
All is below 15. So that is my message to, it's an individual decision. Last question goes to Rishiji. It is a very tricky question. What is your advice for your fraternity regarding professional duty vis-a-vis personal safety? Ethical dilemma.
I mean, all of us are very conscious of the fact that we have, sworn to a profession where we have to do everything possible in order to, take good care of our patients to the best of our knowledge, and we would not be correct if we do not take that interest in mind because of our fears. At the same point of time, I would also like to quote old sailors' kind of a proverb, which says that when the seas are rough, you don't really venture out too aggressively into those seas. So despite the fact that we are sown and we continue to take care of our patients, that doesn't prevent us from using common sense, and that doesn't prevent us from doing things in a way that are safer, not only for us as individuals. Sometimes the senior people are in the more of a policy making, but people who are under our care, our residents, our nursing staff, and our families. So we are also answerable and responsible for them. So we have to use the best of our knowledge to the best of care of the patients who present to us, but we should use our common sense. We should use, we should modify the standard practices so as to make them more and more safe. We must treat every patient that we are seeing right now as a potential case for COVID. So it's kind of a universal precaution that we should be looking at. And I guess it's choppy waters. And again, the one thing that I said earlier, I would like to straight that sometimes in our zeal and aggressiveness to provide the best of care, the state-of-the-art care to one patient, if we compromise the entire hospital and the hospital gets locked down, then probably we'll be harming more in the society than one or two patients that we will be helping.
Excellent. My yorker over here is that, as you said, we chose the profession knowing the risk. Your parents knew, and they allowed you to be a doctor knowing the risk. Your wife perhaps took the chance to marrying a doctor. But what about your children? They didn't choose their father to be a doctor.
Yes.
So why should they take extra risk to lose their father?
I mean,
So if you see from that angle. So again, I would say, you have rightly said, you have to make a very fine balance. We have to convince our patients, look, this is a crisis period. We cannot strive for optimum therapy, the ideal therapy, the best of therapy. We will have a working therapy for the time being. Because I have to save you, you have to save me. This is a mutual contract. So we cannot say that all ethics, we have to go blindly to save my patient. Here, it may not sound so ethical, but I think everybody has to protect himself first. Your family comes first. A patient can have another doctor, but your child cannot have another father. So we have to strike a balance somewhere, and better not shy away from the fact. Don't be hypocrite. We all have to protect ourselves first, take proper care, do what is not really necessary and essential for your patient, and then also try to do some compromised treatment for the time being, hoping for the best. I think that is my motto. What about you? Any second, third, fourth opinion?
Yeah.
Yes.
I quietly agree with you two both, because to give best care to your patient, you will have to take your protection first. And at the same time, you should not endanger your co-workers, your other patients, and the society at large to give this infection to the society. So to a greater interest, you should take your personal protection first. This is ethical, not quite ethical.
So we have come to the formal thing. I think we have got a few minutes left. We have got 9 questions over here. Let's see what are those. Dr. Rishi, viral myocarditis is a known entity and is seen even without cytokine storm. So corona may cause simple myocarditis too. Is it not plausible? Dr. Anil Virmani.
So in the first around 3,000 patients who were studied in Italy, who and out of those patients who were clinically diagnosed as myocarditis, and mind you, these are those patients who are not the mild or the moderate degree of infections. These are the really serious people who are admitted in your emergencies and in your ICUs. And even when you had a clinical diagnosis of myocarditis, none of those patients could be proved as myocarditis when biopsy was done. And in none of those patients, we can find the viral RNA or the viral genome, although there were inflammatory changes that can come both in the cytokine storms as well as the viral infections. Till now, we do not have any conclusive evidence that virus per se infects the myocytes and the cardiac tissue.
To be fair to Dr. Virmani, that we know that there is adenovirus, TOC virus, which can cause myocarditis. So I won't be surprised if somebody has found an RNA in the myocardium tomorrow. Yes. So it is always a possibility. It is always a possibility, may not be proved so much. But anyway, the treatment does not change, whether it is due to direct viral invasion or by cytokines. So next question, Minalji, you please keep the question up, please, for me. I can't see the second question. You have come down. Please go up, Minalji.
No, you'll have to do it yourself.
Achha, Dr. Ambuj.
You'll have to do it yourself.
Dr. Ambuj, do you think that calcium channel blocker would be ideal over ACE inhibitors and hypertensive initiating treatment? I think it is already answered. I won't waste time on that.
Yeah.
Next question, audience. COVID virus positive ACS and respiratory failure. How to manage this type patient? Dr. Solanki, who will take it? Dr. Rai, Ambuj Rai, please. COVID virus positive ACS.
Yes, I guess.
Please answer. Dr. Ambuj
Yeah,
Rai, can you hear?
can you get? Yeah. So I would say we have to be very careful, as pointed out earlier. A lot of these patients may just be part of the myocarditis, and so we shouldn't, unless he's having definite chest pain and other symptoms suggestive of coronary artery disease, we should not rush him to the lab. Have a conservative line of management, because he's not STEMI. It could just be a myopericarditis also. So you could have a conservative approach to him. Watch him over the next 24 to 48 hours, how he shapes up, and then think about invasive procedures.
Yeah, absolutely. As in respiratory failure patient on ventilator, you are not rushing him to cath lab. You are treating him conservatively and hoping for the best. Yes. Dr. Rahul, if a coronary CAD patient develops COVID infection with complaint of shortness of breath, we should continue beta blocker. But if he develops ARDS, then should we stop beta blocker? So simply, is beta blocker contraindicated in ARDS, whether COVID or not? It is contraindicated in acute bronchospasm. But what about ARDS? Generally speaking, is ARDS a contraindication for beta blocker? Question goes to Dr. Rautre, please.
Yeah, I don't feel it is contraindicated. If the patient is taking beta blocker, let him continue, but we should not start beta blocker in a patient of ARDS. This is a different etiology. This bronchospasm is a different etiology. But I think if the patient is having, say, failure, at the same time on beta blocker patient developed failure, then we can think of discontinuing or increasing the diuretics, etc. But
Rishi, on it?
Many of these patients, in practical scenario, many of these patients would be landing up in shock. So I believe that, this question would not be so much of a...
If
they're in shock, we will have to discontinue.
Again, a question from Dr. Rahul. 30-year-old boy with ST elevation in ECG, with elevated trop and X-ray showing pneumonic patches, presenting within 12 hours of shortness of breath but without chest pain. Should we thrombolyze? No. This is a case of COVID infection with or without myocarditis.
Yes.
Not going to thrombolyze this case. Unless you show by echo that there is a regional wall motion abnormality. Yeah. This is one of the cases where you do an echo before taking.
I would. Yeah, definitely. We rule out myocarditis kind of situation, and echo is a good modality, as you said here.
If the chest X-ray or CT scan of the chest point towards COVID infection, then that takes priority. That is the first priority. Whatever else is underlying, stroke, heart attack, all are second priority in this today's scenario. Dr. Shah is asking, is it mandatory to use anticoagulation in COVID-19 patient? If yes, why? Is D-dimer measurement in COVID-19 patient mandatory? We have partially answered it. Dr. Rishi, will you take it? Is it mandatory to do D-dimer?
As Dr. Ambuj said that, many of these patients who get admitted to ICU are hypercoagulable states, and we may consider giving, but that would be a general precaution for all ICU admissions and kind of admissions, and nothing specifically different.
You are not doing D-dimer in all your COVID positive patients.
No.
Unless there is some special suspicion. Dr. Suldev Singh, how superior is FNOCAR compared to Silen? I don't think this is to be... sorry, boss, we don't discuss it here. We have got another forum to discuss it. How, Dr. Mizan, how can you treat COVID patient with tuberculosis and effect on CVD? Is anybody keen to take it? Raise your hand, please. Let me say, tuberculosis treatment, if he is already on, should go on. You do not discontinue, because there will be resistant strain. You will come out of the COVID with 3% mortality. But if you now develop resistant tuberculosis, you are in a soup. So better to carry on with tuberculosis treatment, better to keep an eye on the liver very carefully, the liver enzymes are going on which side, maybe other precautions of the side effect of the individual drug, nothing special about it. Dr. Bashav Mondal, HCQ, ivermectin, remdesivir and antivirals in COVID treatment prophylaxis. I think ICMR has given very clear-cut guideline, and we are as individual have got no right to say yes or no to that. As long as we are India, we have to go by the ICMR guideline. ICMR has given very clear-cut guideline, step by step. So we should follow that. We should not discuss and come into controversy into it. Dr. Virendra Kumar Goyal, how to differ TROP-T value from acute MI without COVID and higher values as a sequelae of COVID? Is there any cutoff range of TROP-T quantitatively, which will say it is STEMI and it is non-STEMI due to COVID? Is there anything like that?
No, I mean,
No.
as said earlier, I mean, whenever the patients are having a leak, troponin leaks, these patients would not be the mild and the moderate cases of COVID infection. They would be presenting as a clinical myocarditis, and you would have respiratory symptoms overlapping with COVID symptoms, and you would have a fair amount of longer duration of disease so as to make a relevant diagnosis. So if you are making a diagnosis of myocarditis, clinical myocarditis, troponins can leak there. There's no clear-cut guidelines to say which cutoff to take for what value here.
I don't think troponin can help distinguish type 2 and type 1 MI.
No.
And most of these people, majority would be having type 2 MI. So, but the troponin will not help you there.
To put you in perspective, Dr. Goyal, forget about COVID. Troponin was a good marker of heart failure. And heart failure with high troponin has got bad prognosis. Even in that, there was no cutoff value from where you can distinguish heart failure from MI. But the pattern, rapid rise and fall of troponin is more akin to heart attack, and rapid rise or sustained rise is more akin to heart failure as a prognostic marker. I think same will hold true over here. Troponin T once goes up, will be sustained in COVID infection perhaps, but it will have a rapid fall perhaps with the MI, but I'm not sure. The next question comes is a long one from Pradeep Pariksha. Are the hypertensive persons taking SNEB at increased risk of infection? We have discussed it. Should we start on other antihypertensive? We have discussed it. Should we start as an ARB once the patient is infected with COVID? If he is not on SNEB already, we have discussed it. Very simply, if he is already on, continue. If he is not on, don't start at the moment. Dr. Ajay Mundekar, what cutoff of troponin is recommended for cutoff? The same, there is no cutoff here. We don't know. Dr. Kizo, do the risk of ARDS in a COVID patient increase in those with CVD? And if so, what are the factors associated? Dr. Ambuj, will you take it?
I'm sorry, I didn't get that. Could you just repeat that?
Do the risk of ARDS in a COVID patient increase if he has got CVD?
Well, this has been discussed in detail by Dr. Rautre. Yes, once you have the disease, generally you have a higher chance of having a complicated course of COVID-19. So yes, there is a higher chance in these patients.
Everything, of all the complications.
Yeah, everything.
Dr. Balakrishna has asked, what are the physiological changes of heart disease, particularly those who are faced CABG at the time of coronavirus spreading time? Those who have faced corona. So post-bypass patient having corona. Nothing special, Dr. Balakrishna, excepting that you have to continue with the medicines, strict control of blood pressure, blood sugar, blood cholesterol, and the healthy lifestyle and eating. That's it. Dr. S.P. Mehta, can we give our normal patient flu and pneumonia vaccine now? We have already discussed in detail. If he is on the routine taking, just go on giving. You may not initiate at this point, wait for the pandemic to get over. It's time. It is also very difficult to get people to give you a vaccine at the moment and get the vaccine. So better wait. There is no rush. These are long-acting things. One acts for 1 year, one acts for 5 years. So why don't you wait for 2 months? Next, last question. Oh, Dr. Saira, what about continuation of SGLT2 inhibitors and metformin in diabetes with COVID-19 in patient does not require ICU? Dr. Rautre.
Yeah. Actually, what the evidence goes, if the patient doesn't require ICU, SGLT2 inhibitors and metformin are to be continued. But if the patient needs ICU, needs hospitalization, if there is heart failure, if there is chances of getting to the ventilator or other things, then we'll have to shift to the insulin.
Very, very precise. And to put you into perspective, we do not use SGLT2 inhibitor as of now in ICU or ITU setting.
Yeah.
We do not still use it. We let the patient stabilize and then only start it. No point exposing a great molecule to unnecessary weathering. Dr. Amulya Kumar Paul, atrial fibrillation with corona, mode of treatment and effect. Anything different from standard therapy?
No.
No. Fine. Dr. Ajay Mundekar, can we think of using disposable plastic sleeve for BP cuff in every patient? Good thought, but how do you get it? I don't know. I really am bugged by this question myself. I don't know what to do with my patient. Have any of you have got access to disposable plastic sleeve for BP cuff? We don't use it. We may use a disposable plastic, just a shield on the patient's arm, and then put the cuff. Maybe. And ask the patient to maintain hygiene, wear a fresh shirt or something, not sneezing on the shirt. I don't know. This is a difficult question. I feel difficult in answering this. Dr. Mohandas, prophylactic HCQ in CHD with stent, what advice? So, just as a predisposing factor, comorbid condition is not yet an indication for HCQ unless, as Dr. Rautra has very clearly explained, two scenarios. Either you are a healthcare worker with a suspected contact or you are a home contact with a proved case. These are the only two categories of people. That was the final question, sir. Dr. Shatyapriya Jha, does viral load matter? Are the patients with bigger viral load having worse prognosis and are more contagious? I think the answer is yes. Yeah.
I think
we have got
the viral load and the cytokine storm.
No tool to measure the viral load. Yes. So maybe a small viral load can produce a big cytokine storm in some people. Yeah. We do not know. But as for shedding of virus, the more the load, the more the shedding. That is common sense. But maybe the prognosis may not depend directly on the viral load. It may depend on the patient's immune reaction to the virus. So,
but generally, if you are infected by a high virus load, like an ICU patient, and that's what the healthcare workers are, they are having a worse outcome.
Yes.
So I think I thank to all my guests over here. You have done a fantastic job. Thank you very much. And the audience and the background heroes. Any last word from the background?
I would only say, it's been rightly said that this is a new kind of a war we are fighting. And fortunately or unfortunately, the doctors here are the soldiers on the front line. So we have to keep ourselves motivated. And as you all have rightly said, we can't be too brave. But we have to be brave, but we can't be foolhardy. So we have to strike that balance and keep all of us motivated.
What kind of solace?
Yeah, go with a positive attitude. Go with a positive attitude, many positive things.
We shall overcome. We shall overcome. We do believe. Okay. I say my thanks from the behalf of the panel to all the audience, to the support team, as well as to the industry to arrange such a beautiful evening for us. I hope the audience has enjoyed. And stay safe, stay indoors, play safe. Stay safe and play safe. That's the motto. Thank you and good night.
Thank you. Thank you.